I'm excited to present our findings looking at trends in the prevalence of national anemia among children in Nepal, as well as the strength of risk factors associated with anemia, looking specifically at the period between 2013 and 2016. So just to start with some background information, as I'm sure most of you are aware of, anemia remains a major public health problem globally, but especially in South Asia, where about 60% of children under 5 are anemic. This is concerning as we know that anemia is associated with an increased risk of infection as well as impaired cognitive and motor development, and also reduced work productivity later in life, which has severe economic consequences. Mitigating anemia is quite challenging because there are many different factors that contribute to it, as well as lead to disparities of prevalence of anemia within a population. Additionally, few studies have explored multi-level risk factors for anemia over time, as well as whether or not these risk factors remain stable looking over time. So we aim to strengthen that evidence by investigating national trends in the prevalence of anemia, specifically looking at children between 6 and 59 months of age, and also looking at the stability of risk factors between 2013 and 2016. And we use data collected through the POSHAN surveys, which I'm sure you're all very familiar with from other speakers that presented today. So just to quickly recap POSHAN, the main goal was to identify links between agriculture and nutrition in order to inform programs aiming to improve food and nutrition security. It was a nationally representative study that sampled from the 3 main regions of Nepal. And data were collected in the same seasons in the same study sites between 2013 and 2016. Specifically looking at anemia assessment, each year a random sample of children under 5 was selected for anemia assessment. So not all the children were followed over time, although some children were visited multiple times. And we defined anemia status based on the WHO standard and then adjusted it for altitude. Because the etiology of anemia is quite complex, we did a literature review in order to create a theoretical framework to guide our analysis. And so you can see from here that we looked at multiple levels, for example, at the agroecological region level, household level, looking at sanitation and food security, looking at maternal diet and nutritional status and education, as well as at the child level, looking at diet, nutritional status, and disease exposure to try to understand how all these different factors interact with one another to influence the child's anemia status. For the statistical analyses, we excluded data from 2015 as it was primarily collected in the Terai region. We estimate the prevalence of anemia each year, and we disaggregated by region as well as by child age. Because there were so many risk factors, we wanted to be able to narrow the focus down. And so we first completed estimated unadjusted odds ratios with each risk factor as a dependent variable and anemia status treated as a binary dependent outcome variable. And then those that had a p-value of less than 0.2 were retained for adjusted analyses. And in these adjusted analyses, we had each risk factor as the dependent variable and then controlled for a standard set of other variables, which included child age and sex, maternal age, and region. And again, we treated anemia as a dichotomous outcome. So on to the results. Here we have the prevalence of anemia. And we see that it is quite high across all years that we looked at the national level. What's interesting is that it significantly decreased between 2013 and 2014, but then increased in 2016. We also see that this fluctuation is also present in each of the regions, and that prevalence is lowest in the hills, but highest in the Terai. Looking at prevalence by child age, we see here that it is highest among the youngest children, which is consistent with other studies that have been conducted in South Asia. Here's just a snapshot of some sample characteristics, which are also some of the potential risk factors that we looked at. And what's interesting is even though the prevalence of anemia fluctuated over the time period we looked at, a lot of the potential risk factors actually improved over time. So we can see that the proportion of children who had experienced diarrhea within the last 7 days actually decreased over time. Maternal factors like education and nutritional status improved, although maternal anemia followed the same fluctuation as that of child anemia. And a lot of household factors like food security and water and hygiene and sanitation also improved over time. Now looking at our odds ratios, so these are partially adjusted odds ratios at the child level. The red line for each of the years, it represents an odds ratio of 1, and those estimates that to the right are reflect greater odds, and those to the left reflect less odds of anemia. So here looking at the child level, we see that younger children consistently and strongly have greater odds of anemia compared to older children, which is consistent with our findings that the prevalence is highest among the younger children. We also see that stunted children have higher odds of anemia compared to those who are not stunted, though this association loses strength later over time. However, consistently and strongly over time, children who have experienced diarrhea show a higher odds of anemia than those who have not. Looking at diet, we focused on meat intake, as we know that meat is high in bioavailable iron. And we see in 2013 and 2014, the association is as would be expected in that children who have not consumed any meat show a higher odds of anemia than those who consumed it 8 or more times in the past week. But this relationship does not hold in 2016, which is interesting. And then deworming, not being dewormed, shows a general overall trend towards higher odds. Looking at the maternal risk factors now, we would expect that children of mothers with lower education have higher odds of anemia, and we see this is the case in 2013 and 2014, but it does not hold in 2016. But what's interesting is that maternal nutritional and anemia status seems to be strongly linked with child anemia, especially that consistently over time, children who are born to mothers who are anemic have greater odds of also being anemia. So this just shows how closely linked maternal and child health status are with one another. In terms of the household level risk factors, we see that consistently those children who live in households that are severely food insecure do show a trend towards higher odds of anemia, but this is not significant at any time point. And then what's very interesting is that these factors representing household wash and sanitation, they all show trends towards higher odds of anemia, but they show different levels of strength. So for example, lack of improved toilet and having an unprotected water source are all very strongly associated with a higher odds of anemia, while the presence of animal feces and open child defecation do not show as much stability. Finally, at the community level, just focusing on the agroecological region. So compared to the mountains, children who live in the hills have lower odds of anemia, and those who live in the Terai show an overall trend towards higher odds, and this is just consistent with our findings that prevalence is lowest in the hills and highest in the Terai. So to wrap up, main conclusions are that our study found that anemia continues to affect the majority of children between 6 and 59 months of age in Nepal. It's interesting that we've seen these fluctuations in the prevalence of anemia, and that they were consistent at the national level as well as at the regional levels, even though we did see overall improvements over time in many of the risk factors. Despite these fluctuations, the stability of the observed risk factors suggests the need to invest in scaling up interventions that simultaneously address maternal and child health care, gastrointestinal infection, and improving diet quality and household sanitation. I just want to thank all of those who are involved in this study, especially the families and respondents, the investigative and technical teams, the government of Nepal, and the funding agency USAID. And thank you all for your attention to my presentation.